my name is Tom Foley, Director of Global Health Strategy at Lenovo Health. Lenovo Health actually started about 18 months ago. Obviously, we're a very large company, but we started to take a look at what are some of the industry problems that have not yet been solved. Because we obviously, getting into the health IT, we weren't looking to compete with the EHR vendors and other health IT, but what were some of the real problems out there that as we move from volume-based to value-based care that we need to solve. So we took a look at the demographics, and these stats hold true regardless of what geography you're in. They all hold true, and that is that we have, and I'm certainly certain that you'll relate to a lot of this, but we have a growing population overall in volume. We have a population that is contracting more and more chronic conditions as they do get older. And regardless of what we do from a regulatory perspective on costs are still escalating. And that all coupled with the idea that we don't have enough physicians and nurses to actually treat the patients. So what is this transformation that we need to do relative to having enough physicians to care for the growing population that needs care? As we all know, and you've talked about just in the previous session, the idea of moving from volume to value, in my view, can't happen unless you have this balance of patient engagement that drives them from awareness to wellness. And the two have to coincide with each other because you can't get value if the patient is not engaged in that same program with you. So ultimately, and so quality of care, value-based care, is all based on whether or not, in my view, whether or not you had the right information at the point of care. And that's where we get into the scenarios that we talk about. And these are three major problems. We did an event a couple weeks ago at Chimes, the fall conference. We did a CIO focus group. And one of the CIOs said, hey, we thought these problems were problems that couldn't be solved. And I want to tell you that these problems are solvable, not 98% of the time, not 99% of the time, but 100% of the time, these problems are solvable. You can have quality of care, value-based care with an EHR platform that has 10%, on average, 10% duplicate records. You can't have value-based care if you have medical identity theft being as prevalent as it is in the network. And we'll get into more each one of these. And then certainly you're at risk relative to not only being at risk being a value-based care and ACO type of organization, but you're at risk in the context of the amount of payment fraud that takes place. So how do you address each one of those three legacy, as I call them, legacy problems in order to move aggressively into a value-based care model? So medical identity theft, an $84 billion a year problem. It's really, quite frankly, outrageous. So we talk about, organizations talk about, hey, I do back-end data reconciliation, right, in order to clean my data. And I often ask questions like, what if Tom Foley, I came in on the east side of town, what if Tom Foley impersonated me on the west side of town, right? And the whole intent was to replicate me. He looks and feels like me relative to the data that you have doing a back-end data reconciliation. I'm looking at the two data sets, I'm at an HIE, and it looks like the right person. I'm merging those records. That's not a good practice. You cannot do, in my view, a back-end data reconciliation process because you don't have the people that are associated to those records in front of you. It's just as much as the probabilistic matching algorithms that most EHRs employ relative to how they find and search for people. So ultimately, medical identity theft it creates impacts the integrity of the overall data, obviously, and if it's not found, it just perpetuates itself. Often folks talk about, hey, I collect the biometric, palm vein, fingerprint, doesn't matter. I collect the biometric, so I should be okay. Well, if you never identity proof the person, you're just collecting a biometric on somebody you don't know. And that doesn't help either. And I'm talking about how do we fix this problem, not just in a one health facility, but how do I, in my network of care, I live in New Jersey, I used to live in New Jersey, I often say, hey, I'm going to Wills Eye Hospital in Philadelphia, I'm going local in Princeton for some care, and I'm going to go to New York City for care. 3 distinct different networks, 3 distinct different geographies that HIEs don't connect. But through the transitions of care and direct messaging, those data records can be passed back and forth. But again, when I receive something, I'm an Epic system, I receive something from an Allscripts system, I might be defining myself differently in each systems, and therefore the data, Thomas Foley, 19 Elizabeth Street, 109 Elizabeth Street, the data doesn't match, so therefore I'm going to create an overlay or duplicate. So a lot of challenges relative to data, and a lot of challenges relative to probabilistic matching of data. And so some substantial impacts relative to the overall cost. I went too fast, did I? Duplicate records. And the same thing holds true with duplicate records. I worked at Allscripts. I was responsible for their direct messaging implementation as part of the VMU2. And oftentimes we felt that when I received information, the EHR could not adequately say, yeah, I know about this patient. It creates a queue, and then you have to go manually reconcile that data. And I've already spoken to the manual data reconciliation. And the fact that most EHRs, by study, this isn't just Tom Foley speaking, but by study, 10% of all data records in an EHR are duplicates. And that all gets fed up, hypothetically, if it's not cleaned up at the EHR level, that all gets fed up to the HIE. And then the HIE does this, in my view, this impersonal data IT effort relative to, let's see if we can figure this out. We don't have the patients in front of us, but let's see if we can figure this out and merge data accordingly without actually knowing who the person associated with it. So $50 actually for to get rid of just a duplicate record. That's what the cost of an average system. So that 10%. If you're a high volume hospital, 10% is at times $50 is a lot of dollars that you're spending unnecessarily. All right, we have limited dollars, so let's spend it on the point of care, not trying to fix a flawed system. I often say we don't really have an interoperability problem. We can send data. Give me a system, give me 2 systems, and I can set up protocols, and we can get data there. What we have here is a challenge on whether or not the system can actually understand the data. Semantics interoperability is more of the problem versus interoperability. So ultimately, and then we also have, oftentimes we talk to clients and they say, well, we have an EMPI. That should work. We're good. We don't need a patient identity platform. And my view is that that's not the right thinking to have, because an EMPI, if the data was at its purest, and we all know the EHR data is not at its purest, but if the data was at its purest, an EMPI can only be 98% effective based on study. So an EMPI, and this is about moving to value. This is, we were working with an ACO in the Northeast. They thought that they had 6 million managed lives in their ACO. As it turns out, they only had 5 million. But they were only counting records. Now, you're an ACO. You're at risk. If you can't move 1 million patients, they're going nowhere. That's a financial problem for that institution. Because, again, they have to achieve a level of wellness improvement in order for the ACO to get paid. So if you have 1 million patients just sitting dormant, that's a huge cinder block in your coattails relative to being progressive and moving forward in a value-based care network. So an EMPI is good, but it doesn't solve the problem, and it will never solve the problem. It's healthcare. We have to get it right 100% of the time. It's because it's someone's life that is actually at risk. And that's really what we're trying to get at here, is how do we solve these legacy problems, help move the industry to a value-based care model, and improve care. And so I'll get into that in a sec. And then certainly payment fraud. And I'll talk more about this in a couple slides. But I will say, you know, if you look at the trends with health savings accounts and things of that nature, we currently spend $824 billion out of our own pocket for healthcare. And that's not too far in the distant future, 2020, it's not far away. And is expected to grow to $2 trillion. And that's only going to put pressure on the pocket, and that's only going to put pressure on this particular problem of payment fraud. So we need to pivot. And this pivoting is not something unique to what Lenovo is talking about. This pivoting is something specific to what the industry has been talking about. And we're here to say that there are very specific opportunities for you to engage in addressing these particular problems. So even the ONC, through their interoperability guide, this is almost a cut and paste right out of the ONC guidelines. They talk about identity, and they talk about how to go about achieving identity, and doing so at a NIST level of assurance 3, which is important. You can't collect the biometric unless you know the person. If you want to know the person, you have to identity proof them at a NIST level of assurance. And we suggest, and the ONC suggests, doing so at a NIST level of assurance 3. And then once they're identified, whether it be through the patient portal, whether it be physically through the point of presence, whether it be through a telehealth session, you want the identity of the person that's engaging in this session so that you can establish one patient, one identity, one record. That's ultimately what we're going after here. And then certainly, I don't know how many folks know this, but the ONC, if the average EHR today has 10% duplicate records, and the ONC is targeting 2017 as a goal of reducing that to 2%. The question is, what is your EHR platform doing for you to help you with that goal? And how is the EMPI being enhanced to enhance that particular objective? And I would argue that it can't be enhanced just purely because it's a probabilistic matching algorithm, not a deterministic matching algorithm. So again, this was cut out of the ONC interoperability guide. This is a really core challenge in the market, and something that we would like to discuss. So I offer a 5-step effort in what you should look at in an overall construct of how do you go about addressing each one of those problems. First and foremost, it starts with identity. It's who is this person? I give you my driver's license, my insurance card, but just because I hold that information doesn't mean it's me. So being able to quickly and efficiently identity proof an individual with using standards with NIST level assurance 3. By the way, biometrics is not yet recognized from NIST as a viable identity identifier relative to identity proofing. But so there is some specific guidelines that we offer. You should be aware or knowledgeable, at least from the ENAC accredited registration authority, because that's all part of MU2 and the direct messaging construct. So we leverage what you know and what you're using relative to moving forward. And then we leverage NAHAM. NAHAM is one of our partners in helping provide the education on how to properly identity proof someone at the point of registration or wherever they might be in a physical presence. And then once we identify you, we assign a unique health safety identifier to the patient, and it's attached to a particular medical record. Now, you might be asking, hey, Tom Foley might be defined in this EHR 15 different times, which isn't unusual, but in some cases. But which one do I pick? That's ultimately the question, and because that creates risk in and of itself. But you got to pick one. The patient's got to be identified to a record set, and you pick one. And then what we suggest, so we assign a unique health safety identifier, we attach that to a patient record, and then we capture a token. Now, the token could be a number of different things. Could be a chip, a smart card, and a PIN. Could be an app on your smartphone and a PIN. Could be a biometric. Could be your health savings account, credit card, your driver's license. Could be a number of different tokens. We could talk more about that later. But so I can now go, if everyone was on the, I'll use New York as an example, same 5 points that we talked about earlier. But if I was in the state of New York, I can go almost any place within the state of New York, and I would actually argue any place in a country, as long as they were on the same authoritative exchange, I can bring my identity with me. It's not about the EHR that you're using. It's not about your HIE. It's not about your health system. It's about me. And where I go using my same identity and attaching to a medical record, that way when that medical record is exchanged, it's exchanged and you can actually use a deterministic matching algorithm to say, yep, that's Tom Foley. No guessing, probabilistic matching. So 100% of the time, you can match a patient using this particular algorithm, this particular construct. So that's important. So it's not, again, I don't want to get stuck in just being able to do this within one health system, because I'm the classic guy from New Jersey, I think, and I'm the classic person that actually goes and gets healthcare where I think I'm getting the best value. Right? If I need to go see a specialist, I'm going to go to a specialist. It might not be in your health system, but the key here is how do I aggregate my data and have some level of confidence that the data is associated to me and not someone that impersonated me, or making sure that I have 100% of the data, the doctor has 100% of the data available to them at the point of care. And that's ultimately what this leads to. And this is the same pictorial, but looking at it across the U.S. And by the way, our solution, not that I'm here selling, but our solution is the only solution recognized by the General Accounting Office as a viable patient identity platform. So we're looking to, how do we fix this problem? Patients go to multiple different healthcare systems for care. I know some healthcare systems don't want to hear that, but that's what they do. But whether they go to your clinics, to your specialty, to your hospitals, even if it's within the same, and you use Athena in your clinics and a Meditech in your hospitals, you still want them to have one identity. And that's what we did up in the Northeast. They had 10 hospitals and about 50 different clinics, and now their patients have one patient identity across their continuum of care, and they have a plethora of different EHRs in that community. So this is in the upper right-hand corner, Midcoastal is one of our clients, and they use this particular platform, and they used a smart card construct, and you can use anything, but this is what they found was, not only did they solve duplicate records, medical identity theft, and payment fraud, they have it with the patient identity. They now created a loyalty program. They use this card as a loyalty program, saying, hey, we're able to aggregate your data. We're able to consolidate your data with 100% confidence that it is, in fact, you. There's no more back-end data reconciliation taking place. We know you. And as a matter of fact, when you go from clinic to clinic, instead of saying the first thing, hey, here's the clipboard, can you fill out that clipboard? You fill out the clipboard once and that information follows you. And so they provided a whole value-based care loyalty program that says we're your provider, come to us as opposed to anyone else. Let's see here. And then just from an ROI perspective, not so much the dollars itself, but the value that it brings to a healthcare institution is enormous. Now I have one patient, one identifier, one record. Now I have absolute intelligence at the point of care. And now I know that I don't have to worry about duplications of, did I bring up the most current or did I bring up the most relative record for Tom Foley when I'm seeing him. And then it has, again, enormous value relative to the care delivery as well as the overall influence and the overall experience within a health system from a patient's perspective. I'm sure you would agree that a quality care, a high level of experience, a positive experience with a healthcare institution will create that loyalty and will create that partnership between the patient and the care team. So that is actually, I am 8 minutes ahead of schedule, but I figured I'd open it up for any questions that you might have. Certainly, if you want to send me an email or we're right out in the booth, if you want to have a conversation about how this would help you, we'd be more than happy to do that. So any questions that anyone might have? I have a question. How many folks believe they have a duplicate record problem within their EHR? Do you sense that there's a need for a patient identifier to help eliminate the duplicate records? Not so much? New system? Is it the fear that because you've gone through meaningful use and you're so, when you say new system, it's just the fear of having to implement a new system?
Well, you have to rebuild it. It wasn't built to the standard.
Yeah, so that's actually an interesting point. So the gentleman is saying, hey, this is a new system. You have to kind of do a whole integration with the EHR, and that actually is, we actually overlay the EHRs. We could have this implemented across your health system. We have, so it's a very thin layer implementation. Within 4 to 6 weeks is our project plan timeline relative to getting this system up. And we've worked with the Athenas, the Meditechs, the Cerners, the Epics of the world, Allscripts certainly. So it really, surprisingly, it's not a deep dive implementation that takes 6 months to a year to implement. So just for clarity, it's I won't say it's simple, but certainly it's not as extended effort as one might think relative to EHR integration. Any other questions? Okay. Well, with that, I thank you for your time, and I